Okay, so I'll start for today. We were discussing hematology last week. Uh, we discussed about bleeding and coagulation disorders, right? Today, I'll take a short lecture. I will discuss two important diseases, which are MRCP favorite topics. Basically, I will be discussing multiple myeloma and Waldenstrom's macroglobulinemia. So we know that there are some conditions where excess amount of proteins are formed, abnormal amounts of proteins are formed. They are called paraproteinemias, right? We all know multiple myeloma. We all know MGUS, monoclonal gammopathy of uncertain significance, Waldenstrom's macroglobulinemia. These are important topics for MRCP hematology, especially. Okay. So let's go through multiple myeloma first. You all know that it is a plasma cell neoplasm, right? It's a tumor of the plasma cells. It's usually you will have patients above 60-year-old. Male and female are equally affected, okay? So you'll have an elderly patient having certain symptoms, and just important to know that the abnormal antibodies that are formed in multiple myeloma are usually IgG mostly, and IgA and light chain disease, okay? IgM is very uncommon to have an IgM multiple myeloma, okay? When you have a high levels of IgM, that will lead your suspicion to another direction. So you have IgG, IgA, and light chain disease. These are the abnormal antibodies that are mostly produced in multiple myeloma. Very rare to have IgM, okay? So you will have a scenario or with a raised IgG or IgA, or it will be mentioned that the light chain levels are high. So basically, you have an abnormal proliferation of plasma cells in the bone marrow, infiltrating the bone marrow, leading to pancytopenia. This cell proliferation causes osteolysis and hypercalcemia. So these patients usually present with features of anemia. They present with features of hypercalcemia. And of course, due to the huge load of antibodies in the blood becomes hyperviscous, okay? So you have hyperviscosity syndrome. The blood becomes very viscous and blood flow to all the organs becomes very sluggish. So this is the basic pathology of the symptoms that are produced in multiple myeloma. And these are very favorite topics: the presence of anemia, hypercalcemia, and hyperviscosity, leading to a diagnosis of multiple myeloma. And of course, renal failure due to the tubular damage, due to the high load of antibodies in the renal tubules, damaging the renal tubules and leading to renal failure. So this combination of symptoms equals almost always equals to multiple myeloma. So this is a very common, a very popular acronym for multiple myeloma features, CRAB. C for hypercalcemia, R for renal impairment, A for anemia, B for osteolytic and bone lesions, okay? The typical bone lesions that we see in multiple myeloma, okay? So this is a mnemonic to remember the symptoms of multiple myeloma. You will have features of hypercalcemia, features of renal failure, features of anemia, and you will have bone pain. So these are the features. As little bit details, you will have a scenario of an elderly patient having bone pains, may even have pathological fractures. They have features of anemia, that is fatigue, malaise, features of hypercalcemia like confusion, polyuria, constipation, abdominal pain, repeated infections, features of renal failure. So you will have these features in an elderly patient. Not necessary to know all the details of the diagnostic criteria. Just remember that presence of more than 10% of plasma cells in the bone marrow, along with CRAB features. This was the typical diagnostic criteria used to diagnose multiple myeloma. The more easier diagnostic criteria would be this: presence of a monoclonal protein in the serum or urine, as we'll see later; presence of lytic lesions on a skeletal survey, and presence of more than 10% of plasma cells in the bone marrow. This is the basic diagnostic criteria that we use practically when we are managing patients, and this will be in your scenario too. Okay, so just if you need to know the levels, the calcium level is usually more than 2.75. The serum creatinine will be more than 177. There will be anemia. There will be one or more osteolytic lesions. Okay, these clues are usually given and help you to diagnose multiple myeloma. Sometimes they give you a globulin level or a total protein level also in your scenario. Okay, so when you see that the globulin level is very high or the serum total protein is very high, you suspect that this is a case of paraproteinemia. And of course, there will be a marked Rolo formation and a very high ESR. It's one of the conditions where the ESR goes more than 100. So your investigations, you will have anemia, you might have pancytopenia, you will have a very high ESR, you will have Rolo formation where all the RBCs are clumped together. The serum electrolytes, the serum creatine will be raised, the serum calcium will be raised. And as we will see later, beta-2 microglobulin, an important marker for prognosis, will also be raised. The serum total protein will be raised. Okay. And after that, the next investigation that you need, the next 3 investigations that you need are serum protein electrophoresis, that's very important to confirm the diagnosis of multiple myeloma. You need these 3 investigations. Number 1 is serum protein electrophoresis. Number 2 is a skeletal survey demonstrating lytic lesions. You can do, usually a skull X-ray used to be done, or you can do X-ray of the vertebra to look for any vertebral lytic lesions. But nowadays, CT scan MRIs are preferred because of the high sensitivity. An MRI spine is usually done. You might find a lytic lesion anywhere. But traditionally, an X-ray skull used to be done where the skull used to show lytic lesions. So in addition to protein electrophoresis, you do a skeletal survey, and very important, you need a bone marrow aspirate to determine the presence of the malignant plasma cells in the bone marrow to confirm your diagnosis. So these are the criteria for diagnosing multiple myeloma. You will be given a scenario where sufficient clues will be given to point a diagnosis of multiple myeloma. These are a few practical tips, usually not asked so much details in the examination, but sometimes serum protein electrophoresis might not be abnormal. You might not get any paraprotein in the serum. That's why you also might have to test the urine for presence of any paraproteins. So that's why it is advised to do 2 tests to determine the presence of a paraprotein, not to rely on a single test. Okay, so you do a serum electrophoresis and either a serum or urinary free light chain, because as I told you, the light chain antibodies might be present in a particular patient with no IgG or IgA. So a serum protein electrophoresis will not detect the light chains. So in addition to serum electrophoresis, we also do a serum or urinary free light chain assay. Okay, serum free light chain assay, that's called SFLC, serum free light chain assay. So that will help you not to miss a diagnosis of multiple myeloma. Serum electrophoresis along with serum or urinary free light chains. Okay. As you can see here, in 20% cases, free light chains are found in multiple myeloma cases without any detectable monoclonal protein in the blood. So this is very important. Okay.
Sir,
Yes, please.
Bernstein's protein is same as the free light chain?
No, that's different. Serum, here you can see in the urine, you might get free light chain, or you might get Bernstein's protein. The Bernstein's protein is the IgG and IgA secreted in the urine. That's different. So that's why you have to look for the light chain separately. Otherwise, you will miss the light chain multiple myeloma. So basic management of multiple myeloma, supportive, of course, you have to treat the anemia, you have to treat the hypercalcemia, the hyperviscosity, you have to treat the infections, you have to relieve the bone pain. Okay. So supportive therapy has to be taken care of. Okay. Uh, according to the complication or the symptoms present. Hyperviscosity managed with plasmapheresis, hypercalcemia management, you all know, hydration, bisphosphonates, anemia, corrected with careful transfusion because the blood is already very thick, hyperviscous. So we carefully transfuse the blood, treat any infections, treat any bone pain with radiotherapy or dexamethasone. And bisphosphonates can also be given to reduce skeletal events. So we take care of the supportive management. Very important because these patients will suffer from all these problems. And the specific therapy that is used nowadays, the basic thing is that it's not a curable disease. Basically, we are treating the patient to increase the duration of remission. Because once you treat the patient goes into remission, the symptoms will recur. Our aim is to increase the duration of the remission. Number two, to reduce complications and to increase survival time. It's not a curable disease. So we aim to treat with these aims in mind. The drugs that are available now and the questions that are asked in your exam is, number one, this is a very commonly used drug in multiple myeloma, bortezomib. Okay. Initial therapy, when patient presents with acute complications, we use steroids. Any acute complication. For long-time therapy, this drug is used, and thalidomide derivatives. In long time back, thalidomide was used. Now, thalidomide derivatives, especially lenalidomide. These three drugs are the most commonly used drugs in multiple myeloma: dexamethasone, bortezomib, and lenalidomide. Combination of these three drugs produce better effects. Okay. If you want to know, and obviously bone marrow or stem cell transplantation. The other drugs are not commonly asked. You do not need to know all these names. These are not needed and not required for you. Please remember steroids. Please remember bortezomib. This will be asked. Please remember lenalidomide and stem cell transplantation. Just remember these few names. That's sufficient for you for the time being. The drugs that I mentioned, this will come in the exam. This will be asked. This has already been asked many times. So much details is not needed. Okay, so this is very important. How do you measure the prognosis of multiple myeloma? As I said, beta-2 microglobulin is a protein that is found in multiple myeloma patients, and a high level of beta microglobulin is associated with poor prognosis and increased mortality and morbidity. Very, very important question. A very favorite question from multiple myeloma. Beta-2 microglobulin. Okay. LDH can also be used as a prognosis, and low levels of albumin also indicate poor prognosis. But please remember beta-2 microglobulin. Very important. It's come several times in the exam. So these plasma cell disorders have a certain spectrum. Plasma cell tumors with low levels of plasma cells in the bone marrow having no symptoms, asymptomatic patient, no organ damage. These patients are also elderly, and this condition has been termed monoclonal gammopathy of undetermined significance. You will be given a case where a patient is 60 to 70 years old, is asymptomatic, incidental examination reveals some level of paraproteins present, usually less than 30 gram per liter. In multiple myeloma, it's more than 30. And there are no clinical features of multiple myeloma. There is no crab or anything. Okay. So when you have an elderly patient presenting with this type of paraproteinemia, low level of paraproteinemia with no symptoms, we do not have to do anything. Just the important thing is that these patients are at risk of developing multiple myeloma in 5 years. So we have to follow them up in 6 months to 1 year. That is the only significance of this condition. So not to be ignored, but not to be overly treated, but to identify these cases in your exams. It has come, you will be given this scenario. Please write the diagnosis as MGUS when you find that the patient is asymptomatic with low levels of paraproteinemia. But the important thing is that if you're given a treatment option, make sure you choose that the patient has to come for follow-up. Sometimes the patient may have a neuropathy. So you can see the difference between MGUS and multiple myeloma, right? The paraprotein concentration is an important difference, right? You can see that the paraprotein levels are low in MGUS. In myeloma, it's high. MGUS patients are usually asymptomatic. Myeloma patients usually have symptoms. Bone marrow plasma cells usually less than 10%, usually more than 10%. There will be evidence of organ damage. There will be no evidence of organ damage. Okay. So this is the difference between the two conditions. There is another spectrum or another condition in between the two, which I'd like to show you and which has been asked in the exam. This is called smoldering myeloma. It's in between the two. The paraprotein levels are more than 3 gram. The plasma cells in the bone marrow are very high, 10%, even reaching 60%. The only difference is that there is no organ damage. The calcium levels are low, creatinine is normal. There is no anemia, there is no osteolytic lesion. None of this organ damage present. This is in between MGUS and multiple myeloma. What is the importance of this condition? Please observe and monitor and follow up. They are also at risk of developing myeloma in the future. So any case where you have a paraprotein level more than 3 gram, plasma cells more than 10%, no organ damage, you will not be mentioned like this, that there is no organ damage. You will be given a normal calcium level. You will be given a normal creatinine level. You will be given a normal hemoglobin level, a normal X-ray. Please answer smoldering myeloma. Okay, so be careful with these three conditions: smoldering myeloma, MGUS, and multiple myeloma. So here is the difference between the three conditions given in a single chart. Okay, you have MGUS at the top here, where the paraprotein levels are low, plasma cells low, no organ damage. Smoldering myeloma, plasma proteins high, plasma cells in bone marrow high, no organ damage. Multiple myeloma, whatever the plasma protein, whatever the bone marrow cells, there must be presence of organ damage. Okay. So more than 10% plasma cells in bone marrow, organ damage, some level of paraprotein, that's multiple myeloma. So this is a summary of the three conditions. So please read your case properly, read your scenario and the investigations given and answer accordingly. This is another commonly asked condition, though the condition itself is not common. It's a rare condition, but it is another condition where you have a monoclonal gammopathy. A single antibody is produced at a very high titer. It's a chronic and a very slowly progressive condition. Very slow. And it's a very interesting condition because it's a mixture of a lymphocyte tumor and a plasma cell tumor. It resembles non-Hodgkin's lymphoma. It resembles multiple myeloma. In fact, it's a mixture of both. Mixture in the sense you have hyperviscosity because of the high antibodies. You have lymphocytic infiltration of bone marrow and other organs causing organomegaly, lymphadenopathy, organomegaly, like the lymphomas. It's a mixture of the two conditions. Very unique condition, Waldenstrom's macroglobulinemia. Okay, so basically, what I told you, this is a condition where you have a high level of paraprotein. And in this condition, you have a high IgM. Remember, I told you in multiple myeloma, you have IgG, IgJ, IgA, or free light chains. In Waldenstrom's macroglobulinemia, there is a high level of paraprotein, especially IgM. Look at your case, look at the clues given in the investigation, you will be given a high IgM level. This will put you to a diagnosis of Waldenstrom's macroglobulinemia. This is number one. This is an important clue. As I told you, it's a hybrid tumor. It's a hybrid in the sense that it involves plasma cells and lymphocytes. In fact, recently, this is another name for this condition, lymphoplasmacytic lymphoma, because it's a mixture of plasmacyte and lymphocyte tumors. Lymphoplasmacytic lymphoma. Not commonly used in the exam, this term, but this is the term that's coming up recently, lymphoplasmacytic lymphoma. So, the difference from multiple myeloma is that this is a condition where you will have organomegaly. You will have hepatosplenomegaly, you will have lymphadenopathy, but there will be no lytic lesions. So in multiple myeloma, bone involvement, no organomegaly. In Waldenstrom's macroglobulinemia, organomegaly, no bone involvement. There are some other differences. I'll come to that later. So look at your case properly, read it properly. You'll have enough clues to help you to come to a diagnosis of Waldenstrom's macroglobulinemia. Obviously, the patient will have features of anemia because the bone marrow is infiltrated with lymphocytes. You have hyperviscosity syndrome, obviously, because high levels of IgM in the blood. The patient will be dizzy, have headache, blurry vision. There will be altered consciousness. If they may even present with Raynaud's or peripheral neuropathy because of the high IgM levels. As I told you, you will have organomegaly. This is a clue that will help you differentiate from multiple myeloma. You have to do all the investigations that we did in multiple myeloma. The points that will help you clinch the diagnosis is that when you do a protein electrophoresis, the IgM band will be very high because of the high levels of IgM. Number one, the gold standard for diagnosis is bone marrow biopsy. You have to demonstrate that there are abnormal plasma cells in the bone marrow. Okay, so these are lymphocytes. These are actually lymphocytes showing plasmacytic differentiation. Features of both lymphocyte and plasma cells. This is the characteristics of Waldenstrom's macroglobulinemia. This will help you clinch the diagnosis. So bone marrow biopsy is the gold standard for diagnosis of Waldenstrom's. So when you have a scenario where you are suspecting Waldenstrom's, how do you confirm your diagnosis? Please answer bone marrow. Okay. Usually the IgM levels are given with the normal range given beside it. How do you treat Waldenstrom's macroglobulinemia? If it's asymptomatic, nothing needs to be done. You just follow up the patient. Once symptoms arrive, then you have to treat the patient. Okay. For hyperviscosity syndrome, obviously plasmapheresis to filter out all the antibodies. And recently CD20 antibodies like rituximab is being used because these markers are found in the lymphocytes present in the bone marrow. So rituximab is one of the drugs that is used. You can remember that. Patients presenting with hyperviscosity, plasmapheresis. If it's asymptomatic, follow up the patient. So this is another summary of the two conditions, multiple myeloma, Waldenstrom's. You may, in your case, please note whether the patient has hepatosplenomegaly, whether the patient has lymphadenopathy, hyperviscosity. Okay. Benz-Jones seen in multiple myeloma, bony lesions seen in multiple myeloma. Okay. So you will be given enough clues to help you differentiate the two conditions. Here you can see the differences like I told you. Okay. In Waldenstrom's, we have IgM. In multiple myeloma, we have these. Okay. Osteolytic lesions in common here. Hypercalcemia common here. Renal insufficiency common here. Organomegaly is here. Okay. So these points will be sufficient to differentiate the two conditions. Both patients are usually elderly. Okay. So I'll keep my lecture short for today. We have 2-3 more conditions to discuss in our next class, like leukemia, lymphoma, very important topics for exam. So I'll finish here for today, and you're welcome to ask any questions if you like. Anyone, any questions, any problem understanding anything? You're welcome to ask any questions.
Sir,
Yes, please.
if they ask in question, what is a confirmatory test for multiple myeloma, what we have to test?
Confirmatory is actually serum protein bone marrow study. You have to do the bone marrow and see the plasma cells. And actually, you have to combine this with the presence of the serum protein electrophoresis. Because if you have a bone marrow with a high plasma cell load, we don't know if it's a smoldering myeloma. So actually, you will be given investigations in your case, and one of the investigations will be mentioned. And the question is usually, what next investigation you want to do? So you will be given a plasma electrophoresis or a bone marrow study, and you will be asked what is the next investigation. So you answer accordingly. Any other questions?
No, sir. Thank you.
Okay, then you can go through these topics and read the questions of previous years. We'll discuss a few more topics in our next class. I'll let you know the date as soon as possible.
One is lymphoma and
Leukemia. We'll be studying lymphoma and leukemia in our next class.
Sir, we have MRCP part 1 in January. So can you make the class in this month itself?
Okay, sure. When is your date? Sorry.
In January 21st.
Okay. I'm supposed to take it December 30th. I will try to take it earlier.
Okay, sir.
so what about the drugs and mechanism?
Oh, yes. In that, the anticoagulants, right?
Yeah.
Okay. I will finish in that one class.
Okay. Thank you.
Deep vein thrombosis, anticoagulants, leukemia, lymphoma. I'll finish in that one class.
Thank you, sir.
Okay. Okay. All the best. Study well, everyone. Thank you.